Okay, well, good morning, everyone, and welcome to Phoenix Children's Grand Rounds, and a especially warm welcome for all of you that were here last week and got stood up. It was a Zoom problem that is now fixed, and so we should be ready to go today. I'm going to introduce the coordinator of the series, Dr. Alexandria Walsh, and she's going to go ahead and introduce the other presenters. Dr. Walsh earned her undergraduate degree from Cornell University and her medical degree from the Ohio State University College of Medicine. She then completed her pediatric residency at University of Chicago and a pediatric hem-onc fellowship at University of Alabama. She is the director of our survivorship program in fertility preservation in the Center for Cancer and Blood Disorders at Phoenix Children's. And she started the fertility preservation program here at Phoenix Children's. In recognition of her service in the field of medicine, Dr. Walsh was named the 2021 Advocate of the Year, as nominated by her peers for the Heart and Hands Clinical Excellence Awards. So Dr. Walsh, I will let you take it away and introduce the other members of your team.
Thanks, John, and thanks all of you for joining us again this week. Apologies for the technical issues last week. Appreciate you coming back. So we wanted to do a two-session overview of childhood cancer for the general pediatrician, giving you some insight into some of the newer treatments that we have and how we're currently treating patients with childhood cancer. Okay. So the idea for this series came about as part of our working group for the Arizona Comprehensive Cancer Control Program. I was invited to join that program and lead the childhood cancer working group for the first time starting in 2018. And I'm co-chair of that group with Patty Luttrell, who is part of Children's Cancer Network, and you will be hearing from her later on in the series. One of our goals that we included in the Arizona Cancer Control Plan from 2020 to 2024 was to provide for Arizona's childhood cancer community through education and community involvement. And we wanted to provide at least 3 opportunities for healthcare providers to learn more about the diagnosis and management of pediatric cancer patients. And we are recording these sessions for pediatricians across the state to view on their own time. So I'd like to introduce our speakers for today. We have some of my amazing colleagues joining us today. First, we will have Dr. Henry, who will be updating you about the treatment for childhood lymphoma. Dr. Henry has been with PCH for many years. He is a leader in the Histiocyte Society across the country. He is our Associate Program Director for our fellowship and all-around great guy. And after that, we have update on leukemia with Dr. Hess. She was a former PCH fellow, one of my mentees, and now specializing in AML, and she is our inpatient medical director as well now. And then I will be following up with survivorship. On August 16th, I hope you will join us again, and we will be discussing brain tumors, solid tumors, and community resources. Stop sharing and let Dr. Henry join.
All right, thank you, Alexa. Okay, so I've been given the task to tell you all about lymphadenopathy in the next 15 minutes. So we will do the best we can. But I was hoping to give you just a nice overview of what to look for, and then briefly what happens when they come to the oncology office. So the differential diagnosis of lymphadenopathy is quite broad, and I thought we'd spend the next 13 minutes going over this slide. I'm just kidding. But the point is that when you have a patient with lymphadenopathy, there's a bunch of things to consider. So the things I like to think about are, how old is the patient? How big are the lymph nodes? Where are the lymph nodes? What do they feel like? Are there more lymph nodes? Are they local, or are they generalized? And how long have the lymph nodes been there? So the important thing to remember is that normal size of lymph nodes does change with age. they're not generally palpable in the newborn period because typically there's not enough antigenic exposure. And the probability of the diagnosis needs to be considered. So for example, in teenagers, an enlarged cervical node could be lymphoma, or if there's inguinal it could be a sexually transmitted disease. Both of these things obviously are much less likely in a 3-year-old. Having said that, the youngest patient with Hodgkin lymphoma that I've seen in my career was 3 years old. So I thought this was a great slide. It's an old slide, but I thought I'd include it. This represents the probability of seeing a particular diagnosis that varies with age. You can see way up at the top is reactive hyperplasia, which is by far the most common reason to have enlarged lymph nodes. And then you have a whole bunch of stuff that becomes less probable, like cat scratch disease, atypical mycobacteria, which is much more common in the earlier years, toxoplasmosis, and the reason why I said it's an old slide is because there's histiocytosis X mentioned. That as a term that probably hasn't been used for about 25, 30 years, and then you have Hodgkin disease and other things. So not all things that look like lymphadenopathy are lymphadenopathy. It's important to consider the congenital lesions like cystic hygroma, a branchial cleft cyst, and thyroglossal duct cyst, although in this case, there's really no lymph node that lives down there that we typically see enlarged. You could see some submental nodes further towards the chin, but it's important to remember these congenital lesions. So size is important. Cervical lymph nodes of 1 to 1.5 centimeters are perfectly normal. Inguinal can go up to 1.5 centimeters and still be normal. Epitrochlear nodes, about 0.5 centimeters. However, supraclavicular and axillary nodes that you can feel are typically not normal, and they need to be investigated. One caveat to this is that it's very common to have supraclavicular nodes that, what you think are supraclavicular nodes are actually very low cervical nodes. Imaging can help distinguish that. So what do the lymph nodes feel like? Is there erythema, swelling, pain, heat? These would all indicate infection or inflammation to be more likely. Reassuring things are soft, easily compressible nodes if they're freely immobile. Not so reassuring are firm, rubbery, matted, fixed, although there's a lot of, this is kind of an overlapping Venn diagram between the two. So you kind of have to consider other things. Like, for example, are the nodes local or generalized? Local lymphadenopathy is usually, but not always, associated with infection or inflammation, but generalized adenopathy is caused by systemic disease. And so in addition to that, you need to look at other features of the reticuloendothelial system, like hepatosplenomegaly, for example. So how long have the nodes been there? So we get this all the time as consultations into our service. So waxing and waning lymph nodes over a period of several months to years. This is very unlikely to be malignant. But I also consider what are some of the associated symptoms. Is there acute and painless enlargement? That's a worrisome finding, unless it's associated with a known infection. But also worrisome are the other systemic symptoms that we talked about, like weight loss, fatigue, bone and joint pain, fevers, night sweats, and all the other things that you get worried when you hear about. This is another old slide, but I think that the point of this is just to say that the mean duration of a certain kind of node, like for example, inflammatory or granulomatous, hyperplastic, neoplastic. If you look at the bottom neoplastic nodes, the mean duration is about 3.5 months. And of course, the standard deviation is pretty large on all of these. Versus hyperplastic nodes, which can be there for almost a year, plus or minus over a year. So it's hard to really say what a node is, but the point is that neoplastic nodes are a a lot less common to be present for a long time versus hyperplastic nodes. So, so what I typically do here is nodes greater than 1 centimeter in any location, except for axillary and supraclavicular, can be observed for actually a few months, and because usually they'll just go away. If there's associated symptoms of weight loss, night sweats, fevers, fatigue, etc., that would prompt sooner investigation. Epstein-Barr virus is a very common, the monospot is not always positive, so it's better to get IgG and IgM for capsid nuclear antigen, and if you can swing it, you can get an EBV PCR. I guess we're fortunate to work in a tertiary care center because we get it back pretty quickly, but it may not be as practical in the outpatient setting. So a lot of times a good history can really solve your case for you. So is there exposure to cats, kittens? That would make it much more likely to have Bartonella or Toxoplasma. If there's, you want to take a sexual history to look for sexually transmitted diseases, and you want to think about inguinal adenopathy. And there's a travel history, looking for histoplasma, Ehrlichia, cocci, Lyme, etc. And you also don't want to forget about HIV. Even though there is, even in patients who you think have absolutely no reason to have HIV, I always check it because sometimes you can be surprised. I actually diagnosed a patient in the outpatient setting with HIV, just doing just for a lymph node consult. This is very rare, but medications can cause lymphadenopathy. Usually caused by serum sickness. I don't think I've ever seen this, but I thought I'd throw it in there just for sake of completeness. So, malignancy can cause lymphadenopathy just from infiltration of the lymph nodes, most commonly leukemia, lymphoma, solid tumors, but also autoimmune diseases are important to keep in mind, JRA, lupus, and dermatomyositis. So, there are regional differences. So when I first came here, I've been here since 2004. So I practiced, not practiced, but did my training in Philly, where I was a resident. The hot diagnosis over there was Lyme disease, and of course, when I came to Phoenix Children's, I remember doing like a morning report type thing with the residents, and there was a kid with lymph nodes, and of course I said Lyme disease is part of the differential, and I was practically laughed out of the room. Here it's cocci, so you really want to consider where the patient is and where the patient's been, like for example on vacation, as part of the workup. Having said that, cocci. And I think any resident who can say this word correctly should get 5 stars. I'm not even going to try. But cocci should be on the differential diagnosis of every workup for enlarged lymph nodes, because you'll never diagnose this if you don't check. And true story, again, when I first came here, I had a outpatient consult for lymphadenopathy, and I completely missed a case of cocci. It was pretty much a slam dunk case, as I found out before. The patient came into the emergency room the next day, and the ED got it in about 2 milliseconds. So it's important to keep this in mind. So my lymph node panel, because we get consults for lymphadenopathy all the time, is this. So I typically get a CBC CMP just for general purposes, looking for abnormalities in the blood cells, what the liver's doing, the kidney's doing, electrolytes, LDH uric acid for looking for signs of increased white blood cell turnover. A SED rate, there are really only a couple things that can give you a SED rate of over 100. And what I've been taught is that the 3 most common things are osteomyelitis, lupus, and leukemia/lymphoma. So if you see a SED rate over 100, those are the things you want to start thinking about. I do an infectious disease panel that you see there that we've already talked about. I do a chest X-ray, and I also sometimes do a quantiferon test for TB if there's a history. This is the reason why you want to get a chest X-ray, because you never know what's going on in there unless you look. This is obviously a large mediastinal mass, something that you'd want to know about before the patient goes anywhere or undergoes anesthesia. So we talked about worrisome signs, but just to rehash this, acute onset of enlarging lymph nodes of greater than 2 centimeters that are not red or painful. Firm rheumatic consistency, although sometimes this is hard to determine. If there are systemic signs like fever, night sweats, or greater than 10% weight loss, so we call these B symptoms for Hodgkin lymphoma. If the infectious workup is negative, and if there's lack of improvement after 4 weeks, then you want to consider consultation with a surgeon to figure out what these lymph nodes are made of. So what comes next? We want to complete any lab work, obtain imaging, refer to surgery for biopsy, and then if the biopsy shows lymphoma or any other malignancy for that matter, you can refer to oncology. So this is kind of my public service announcement because this has happened, unfortunately, way too many times. You don't want to start a patient on steroids for any amount of lymphadenopathy unless you are absolutely sure of a diagnosis. We get lots of patients, unfortunately, who were seen by an outside physician who had lymphadenopathy. Didn't quite know why, but they decided to give steroids to quote unquote shrink it. And of course, there's a high chance that they're treating a steroid-sensitive malignancy like leukemia and lymphoma, and then we have a undiagnostic mess. So I know that. Sometimes it's hard to resist the urge to help the patient, but you really want to make sure you get a diagnosis before you put them on steroids. So consultation with an oncologist, and I actually present this slide with a little bit of hesitancy because I certainly don't want to turn away any consults, but I think just to set expectations, I think that we can only confirm the presence of the lymph nodes. We're not really going to get any closer to figuring out what the lymph nodes are in the patient. For that we need either a histology or titers or some kind of infectious workup that demonstrates infection. We can help direct the workup though, and if that's what you want us to do, then we certainly can. So in the oncology office, once we have a diagnosis, we would complete the staging with imaging, have a discussion about the diagnosis with the family, fertility preservation that Alexa has already mentioned and we'll talk about further. It's very important for patients who are of appropriate age. And then we do central line. We talk about treatment that could consist of chemotherapy and or radiation. I put involvement of the primary care physician in there because primary care physicians still, I think, need to be involved because they're still kids and they're still growing and they still have needs outside of the oncology realm. So I really encourage PCPs to maintain an active role in our patients' care. So with that, I will stop. Please contact me or us anytime. We're always happy to discuss cases with you. So thank you.
Hi, I'm Jen Hess, and I work with Mike and Lexa in the Center for Cancer and Blood Disorders. And I'll be talking about pediatric leukemia today. So here are a few of my objectives to review kind of the epidemiology and etiology of leukemia. My focus will be, like Mike's, on the clinical presentation of leukemia and when you should be worried, and certainly give us a call. I'll talk about the lab abnormalities, which can be indicative of childhood leukemia, and then also go over our initial approach to management and how to educate families when you have a concern. Leukemia is the most common pediatric cancer in the United States, and we divide it into the two cell lines, or the two types, acute lymphoblastic leukemia and myeloid leukemias. By far and away, the most common is the acute lymphoblastic leukemia, which makes up a quarter of all cancer diagnoses in children under the age of 15. And there are about 3,000 new cases each year in the United States. Interestingly, the incidence among all racial and ethnic groups is highest in Hispanics. And obviously, we take care of a large Hispanic population here. Myeloid leukemias are far less common, making up only about 20% of childhood leukemias. The majority are acute, so AML, but we also do see chronic myeloid leukemia in children, as well as juvenile myelomonocytic leukemia. And while not nearly as common as in adults, we do see myelodysplastic syndromes in children here. So it's really unclear why childhood leukemia happens, but we do know that there are some genetic predispositions that have to do with syndromes that constitute chromosomal instability, like trisomy 21, but also chromosomal imbalances like trisomy 21, but also chromosomal instability syndromes like Bloom syndrome and Fanconi anemia. We also see problems in cell growth and signaling syndromes, such as neurofibromatosis, be a predisposing condition. However, the majority of cases are due to somatic mutations and are not related to inheritance. The main environmental risk factor for development of leukemia is ionizing radiation. And quickly, a little pathogenesis review. So on the far right, you will see the lymphoid stem cell, and that is where childhood ALL will originate in the T and B lymphoblasts. Moving over to the middle is where AML originates in our myeloid stem cell. And to put it most simply, there are a series of genetic mutations that lead to abnormal hematopoiesis. So in essence, leukemia is a clonal disorder in which there's a malignant transformation of a stem cell, and that stem cell has increased rate of self-renewal, decreased rate of self-destruction, and then has abnormal differentiation. On the right, you can see, again, how we break this down. 97% of childhood leukemia is acute. About 75 to 80% is ALL, 20% AML, and interestingly, 1 to 5% is either an acute undifferentiated or mixed lineage leukemia. So probably the most important part is, what does it look like when these kids come to your office? And so most of the clinical presentation stems from the bone marrow invasion. So there's anemia, the child stops playing, is very tired, looks pale, and then has compensatory tachycardia and tachypnea. They could be neutropenic or functionally neutropenic, and so are likely having fevers, but may have mouth sores and other pretty significant infections. And oftentimes there's thrombocytopenia with bruising, bleeding, and then any child who no longer wants to bear weight or has refusal to bear weight because of bone and joint pain or walking with a limp, that is a worrisome sign for a possible leukemia. The lymphoid system infiltration will also lead to our presentation of lymphadenopathy, oftentimes very bulky and can be mediastinal, but also seen in hepatosplenomegaly. There can be CNS palsies and also evidence of raised intracranial pressure, and this occurs in less than 5%, but is something that we are always looking for. And then there also can be testicular involvement in boys, not as frequent at diagnosis, but certainly seen at the time of relapse more commonly. Just like the differential diagnosis of lymphadenopathy, all these generalized symptoms have lead to a broad differential, and this is certainly not all-inclusive, but these are the things that are most commonly seen that can look like leukemia. So infections, EBV and CMV are big culprits, but also parvovirus, and you see pancytopenia. Rheumatological disorders like lupus and JIA, and then, as you know, neuroblastoma can involve the bone marrow, so sometimes that can present like an acute leukemia. And then other bone marrow failure syndromes like aplastic anemia. And so what is a good place to start when you have a suspicion? Obviously a CBC. Most frequently you can see a leukocytosis, but you also can see a leukopenia. Oftentimes there's a neutropenia, anemia, and thrombocytopenia. On the peripheral smear, you can see blasts, but the absence of blasts does not rule out leukemia, as they still could concentrate it in the bone marrow and not have mobilized to the periphery. We always ask for a DIC panel or a COA panel. There are oftentimes there's an element of coagulopathy in our patients, and which can be life-threatening in some forms of AML. And then our chemistry is looking for tumor lysis syndrome. Obviously, when there's rapid cell turnover, we can see hyperkalemia and hyperuricemia with AKI or overt kidney failure. That is a part of that. So here, we usually can get a diagnosis quite quickly off the peripheral blood because we have an excellent flow cytometry lab. But while that is being looked at and we're getting the child ready for procedures, we will always do a chest x-ray to evaluate for a mediastinal mass before they obviously undergo any type of anesthesia. Eventually, we'll do a bone marrow aspirate and biopsy. It's important for us to look at the morphology and also the cellularity of that sample, but we have become very sophisticated in using cytogenetics, FISH, and other molecular studies to better characterize the leukemia. We always do an LP and get spinal fluid to evaluate for CNS involvement as well. I thought this was an interesting slide because oftentimes, as many of you know, we say that we can get kids into a clinical remission after 1 month of treatment. And so parents always ask the good question of, well, if we're in a clinical remission, why do we have to continue this for so long? And if you look at the numbers, this is why. Because we just start with such vast amounts of leukemia, and so it does take quite a bit of time to eliminate the minimal residual disease. So treatment for ALL, not AML, but ALL, has really been revolutionized by risk stratification. So we rely heavily on this to know how much leukemia or how much treatment or chemotherapy a child needs to treat their disease without leading to excessive toxicities. And so age, presenting white blood cell count, extramedullary involvement, and your cytogenetics are key in your risk stratification. And then treatment consists of systemic chemotherapy, CNS treatment, as well as prophylactic intrathecal chemotherapy, and radiation in some cases. The complete treatment course is long. It's 2 to 3 years. And I thought this was a good slide to show you the risk stratification. Age is one of the big players, and if you're between the ages of 1 and 10, you will do more favorably, as well as if your initial white count is lower than 50,000. While B cell is a bit more easy to treat than T cell, we are approaching about somewhat similar survival with newer treatments. Genetics do have a big role in what we do. 85% of the malignant clones will have a chromosomal abnormality, and some of those are targetable, and we do know which are better players. Obviously, CNS involvement is less favorable, and then the greatest prognosticator is what we call minimal residual disease at the end of induction. So we go back into the bone marrow to look for the presence of leukemia, and if we are able to see less than 0.01%, we know that the patients will do much better. Quickly, pre-B-ALL is the single most common childhood cancer. It's 85% of ALL, and you might see it referred to as pro-B cell, early pre-B cell, and pre-B cell. They're all the same, okay? T-cell is a little bit harder to treat. It's less common. It's about 10% of childhood ALL and is seen more frequently in males. There's no ethnic variation, but we see it more frequently in late childhood, adolescence, and young adulthood. This is characterized by a mediastinal mass. Up to 75% of patients will have that. So they'll also have, we worry about associated pleural effusions, SVC syndrome, pericardial effusions. Philadelphia positive ALL is a more rare form of ALL that we see. It makes up about 5%. It can be T or B, most frequently B cell. And it is characterized by a translocation between chromosomes 9 and 22 that leads to a BCR-ABL1 fusion protein. Historically, kids with this did very poorly until the tyrosine kinase inhibitors like imatinib and statinib came along, and they really revolutionized the treatment of Philadelphia positive ALL. Now, using TKIs, we have an event-free survival nearing about 80%. However, these are very hard leukemias to treat, and there still are high rates of treatment-related morbidity and mortality. And then to move to AML, this is seen much less frequently than ALL, but we do know that we have to initiate therapy rapidly in these children, and there are fewer individual drugs that are effective alone in these patients. So we have to do an induction and then a very intense, condensed intensification. So there's no prolonged maintenance like we see in ALL, but we have to bring these patients much closer to aplasia than for ALL, and so we do see a lot of, or we have to balance the risk for serious infection in these patients. And they can frequently require bone marrow transplant for cure. Lastly, the mixed phenotype and undifferentiated leukemia is very interesting. So these cells actually co-express cell surface markers from multiple lineages, or they're just such early precursors that they don't express lineage-specific markers. And so it's always a bit of a discussion in how to treat these types of leukemia. Infant leukemia is namely in children less than 12 months of age. It makes up about 2% of childhood leukemias. And these little babies tend to present very sick. They'll have high white counts with massive organomegaly, profound thrombocytopenia. They almost always have CNS involvement, and it's very hard to get these babies into a remission early. They're very biologically unique leukemias, and their blasts have a lot of fetal characteristics, which can be really chemo-resistant, and often are characterized by the MLL or KMT2A 11q23 rearrangement. And I thank you for joining us today.
Okay, we don't have a whole lot of time, but I wanted to spend a few moments talking about childhood cancer survivors, which is my particular area of interest. So I love this picture because it shows you the differences in patients who are treated with treatment for childhood cancer. The patient on the right was treated for childhood acute lymphoblastic leukemia. These are identical twins. And you can see that she's shorter, and she also has some developmental disability. So just as a very quick overview, childhood cancer incidence. So leukemia is about 1/3 of all cases, and brain tumors make up about 20% of all cases. And together, leukemia and brain tumor survivors make up our biggest population of childhood cancer survivors. Childhood cancer is still rare, but it is, because we're becoming better at treatment for childhood cancer, we have more childhood cancer survivors than ever before. Childhood cancer treatment is one of the great success stories in modern medicine. In the 1940s, there was an overall survival of about 10%. And in 2019 and beyond, we are up to about 85% overall survival. However, childhood cancer is still the leading cause of death by disease in patients ages 1 to 15. Improvements in therapies and supportive care have led to dramatically increased survival rates over time. and 1 in 285 children will develop cancer by the age of 20. So there are now an estimated 600,000 childhood cancer survivors in the United States. That means there are 1 to 2 cancer survivors in each high school in the United States. So in all of your general pediatric practices, you will be caring for childhood cancer survivors. There are at least 3,000 childhood cancer survivors in the Phoenix area diagnosed in the last 10 years. So long-term side effects really vary quite considerably with the therapies that these patients receive. But overall, you may notice fatigue, endocrine abnormalities, including metabolic syndrome, obesity, bone health issues, growth failure, cardiac toxicity, pulmonary toxicity, auditory, ocular toxicities, school and brain functioning issues is really the biggest problem that we see overall, infertility, and then secondary malignancy risk. So this is a paper from a paper that was published a while ago now. But you can see at that time, overall for everybody who was diagnosed with childhood cancer, 82% survived and 18% did not. Of the 82% who survived, 72% of those had at least one chronic medical condition. And most of these were fairly high grade. So you can see 25% were grade 2, 33% grade 3, and 10% grade 4. So if you break this down and compare these toxicities in survivors to their siblings, you can see that across the whole spectrum of potential side effects, siblings were much less likely to have the complications than survivors. So for example, for major joint replacement, survivors had a relative risk of 54 times higher than their siblings. And for congestive heart failure, survivors had a relative risk of 15 times higher. And then development of a second neoplasm was 15 times more common in survivors than siblings to develop their first neoplasm. So I just wanted to touch on some of the more common side effects that we see. For hearing loss requiring a hearing aid, this is a multivariate analysis looking at what risk factors are most predominant for that. And cisplatin really is the biggest culprit in terms of chemotherapy agents that we give. Neck radiation and head radiation are also big players in that, brain radiation and craniospinal radiation. So it is primarily our brain tumor survivors who have hearing loss, although other patients who get cisplatin, including hepatoblastoma and germ cell tumors, are also at risk. In terms of heart health and survivors, all childhood cancer survivors are at increased risk for cardiovascular disease, mainly due to the chemotherapy agents that they've received, as well as radiation to the chest or the lungs. And then we also need to take into account multi-organ system dysfunction that may have occurred if these patients had a septic episode or were in the ICU on pressors for whatever reason. In terms of chemotherapy risk, anthracycline chemotherapy is most often to blame, and it damages the myocytes, which are destroyed or damaged, and then the remaining cells hypertrophy and try to compensate. Late effects that are seen in survivors treated with anthracyclines include left ventricular dysfunction, heart failure, and even cardiac death. We have had some survivors need heart transplants. They may be asymptomatic or symptomatic. These symptoms are difficult to diagnose in younger patients. Risk is affected by cumulative dose, age at treatment, female gender, and radiation. And then for infertility, which is another of my areas of interest, the risk of infertility is one of the most common life-altering treatments experienced by long-term childhood survivors. So we see patients in our survivor clinic who really wish they could have preserved their fertility, and that is heartbreaking. The biggest culprits for risk of infertility is cyclophosphamide, ifosfamide, or temodar, which are the alkylating agents, as well as radiation to the abdomen and bone marrow transplant. So treatments for childhood cancer puts all patients at risk for infertility, but those who have had a bone marrow transplant, higher dose alkylator agents, who are older at diagnosis, or who may have a genetic predisposition for infertility are at higher risk. For most of our diagnoses, it is hard to predict who will relapse. Relapse patients are almost always infertile based on the amounts of chemotherapy that they need to receive to get into remission again. And even one dose of systemic chemotherapy will decrease the sperm counts to near zero. And we also know that creating a family is very important for our survivors. So we now have options for all ages and sexes for fertility preservation here at PCH. For prepubertal females, we can cryopreserve part of an ovary, and that's part of a clinical trial here. This is only available for high-risk patients, but we do pay for all of the costs for doing this if they meet criteria. For post-pubertal patients, they can either have the ovarian cryopreservation, which again is just removal of an ovary, or they can actually go through an IVF-type cycle and have oocyte cryopreservation done. And again, we have funding to help cover the cost. For prepubertal males, this is hopefully going to be rolling out in the next couple of months. We can actually cryopreserve a testicle, which will be done with our urology colleagues, and our IRB has been submitted. That's working its way through the process. And again, we have funding to have that covered for patients who meet criteria. For postpubertal patients, those are the easiest of all, and they can take advantage of sperm banking, which again, all costs are covered for all of our cancer patients in that case. I also just wanted to say a few notes about neurocognitive outcomes. So almost all of our childhood cancer survivors are at risk for having difficulty in school, ADHD, and cognitive dysfunction. Cranial radiation and intrathecal chemotherapy are the traditional risk factors, but there is now awareness of increased cognitive risk in other childhood cancer survivors, including those who've received radiation to the chest and neck alone. This can also be a combination of several other late effects. So if they're having multiple other complications for their health, or at risk for childhood cancer, for neurocognitive outcomes, and then hearing loss puts them independently at risk for school difficulties. Overall, many of our side effects that we see in our childhood cancer survivors are similar to aging, which I think is very interesting. Cardiomyopathy, left ventricular dysfunction, premature menopause, hearing loss, and tinnitus. So we're speeding up the aging process by giving these patients chemotherapy, radiation, and transplants. And I like to think of these patients on a complication continuum, which you don't have to remember, but it's just, I just want to emphasize that there's a spectrum of complications in survivors. So for example, a low-risk Wilms tumor patient may have very few or no complications that we can identify. Low-risk leukemia patients also have very few complications. And then solid tumors who are metastatic at diagnosis, they're going to be in the moderate category, as well as Hodgkin's disease survivors and brain tumors survivors. And then bone marrow transplant patients with graft versus host disease, or any bone marrow transplant patient really has a high risk for long-term complications. I think I'm going to skip this in respect for everybody's time. But we are working on a new note template. One of the fellows who's graduating this year, Dr. Aaron Good, worked with me to come up with a note template for general pediatricians that will better meet the needs for information that's available quickly and easily for you. So keep a watch out for that if you're seeing our survivors in your general pediatric clinic. Please refer your survivors to us. They don't need to have been treated at PCH. We will coordinate getting the records and needed referrals, and we will send the treatment summary back to you. So if you have any questions, please email us at ccbdsurvivor@phoenixchildrens.com or just call the CCBD number. But we want to take care of these patients. and help you take care of the patients. Just want to show you our current survivor program. We have a multidisciplinary survivor clinic for general oncology survivors with Dr. Newburn as our endocrinologist. We have a bone marrow transplant survivor clinic run by one of our amazing physician assistants, Kristen Beebe. We have a low-risk survivor to cover the needs of those patients who don't have a lot of long-term side effects but still want to be seen every year. We have a neuro-oncology clinic for the bone marrow transplant survivors with a radiation oncologist, endocrinologist, and physical therapist as well. And then a cardio-oncology clinic with our heart failure specialists joining us to meet the needs of those patients with heart issues, status plus chemotherapy. We're still working on our best transition plan for adult survivors of childhood cancer. I know this is a struggle for many of our specialties, and trying to think about the best way to transition them back into the community with adult care. And thank you very much for your attention. I'd like to take any questions for any of the speakers in the few minutes that we had left. John, did you have any questions come through?
There are no questions in the chat right now, but we can give people a time to. I can't see who's there in person and if there's anybody with hands raised there, but if so, you could take them first.
In the hot seat. They're saying they don't have any questions.
Okay. Well, we'll give it a few minutes. I just wanted to make a comment. I thought this was really well done in the sense that I think it's very hard for you all that are oncologists to, do a lecture for general pediatricians in a way that's not going to be way over our heads. And I thought you really hit the mark today. It was very focused on Dr. Henry, the practical points of which lymph nodes to look for and what workup to do before sending the workup. And Dr. Hess also hit the mark. And I didn't know much about this survivor clinic, so I think it is something that for the general pediatricians on the community that have tuned in, I think it would be a no-brainer if we have somebody who's moved from out of state and they don't know about this clinic. It seems like a no-brainer that you'd want to have them seen by an oncologist and follow up. So.
I also just wanted to mention that the fertility program is also available for non-oncology patients who are getting therapies that might be toxic to their fertility, including renal patients, neurology patients, GI patients getting Cytoxin and other agents. So we're starting to expand to other areas of the hospital as well. And you can put in a consult order for a fertility preservation consult that will automatically notify us.
Okay, how about as a hospitalist, sometimes we'll diagnose kids that will have, require some pretty heavy-duty rheumatological drugs. I really don't, it's not something that's necessarily on my radar to be, usually when we, have somebody who's pretty darn sick and maybe they were in the PICU or we get them as a transfer and everybody's thinking about saving their lives. It's not something that we necessarily think about on the wards about their, what's their fertility going to be, 20 years from now. But what would be the top ones in other specialties that you would say we should be thinking about and referring them to your fertility clinic?
So really anybody who's getting Cytoxin or you're planning on giving Cytoxin to is the main culprit in other specialty areas. So that does include those lupus patients who are very sick, and some GI patients and renal patients too. So if they're getting a certain cumulative dose, they should have fertility preservation offered to them. But I think the easiest way, if you have questions about a patient, is just put in a fertility preservation consult, and then we can coordinate with you whether that patient might qualify. Now, if they're very sick, it is difficult, even for our oncology patients. But it is amazing what we are able to do on short notice. The other population is the transgender population receiving hormone therapy if they would like to take care to have fertility preservation as well.
Okay.
Okay, we have a question from Mario Otto, who's our our chief. What resources do primary care practitioners have when taking care of childhood cancer survivors, and how can they access that information? This is a question often asked. Well, first of all, they have the treatment summary that we create for the patients, which has a lot of information. There's also a great deal of information on the Children's Oncology Group website, and we also have created, there are various resources such as SurvivorLink and others where primary care physicians can log in and see what medications patients received. But we would like to, be the resource for the community for questions, because the side effects really vary depending on the cancer diagnosis and treatment received. Thank you for the question, Dr. Otto.
And I have one more question on my own along the same lines. I'm somewhat spoiled in that when I get a cancer survivor, it comes into Gen Peds clinic. I have a lot of cell phones of those of you, and if I have something I really want to ask, I can usually get a hold of you. But for practitioners out in the community who don't have those contacts, what would be the top 2 or 3 things that you can think of where a patient has gone into their primary care's office, they're a cancer survivor, and you kind of really wished that the pediatrician had reached out to an oncologist, but they didn't do it just because they didn't either know to or they didn't have access to it. But what are the things that residents and others that are listening could think of that, oh, gee, if I face this situation, I probably should reach out?
That's a really good question. I would say the biggest factor in terms of long-term side effects is radiation. So I would definitely ask your childhood cancer survivors if they've had radiation or not. And if they have, then they really need to be seen sooner. We've caught many thyroid malignancies, skin cancers, other issues because of the radiation treatments. So those patients really should be a priority. The other thing is helping to coordinate any available community resources for the patients. So they look normal most of the time, but they have a lot of learning difficulties, so we end up sending them for neuropsychological testing. But we often need coordination help with mental health therapy, psychiatrists, and things like that. But we're happy to see those patients in our clinic, refer them for neuropsychological testing. I think we can get them in higher on the list, for here PCH if it's needed. And we prioritize those patients who are at highest risk and who are doing poorly in school. But we've really been able to impact a lot of the survivors in how they do, because we can get them the support that they need. They may just need extra time for test taking or a quiet space to take their tests, and they end up doing really well. We have a lot of survivors who are doing amazing things, going to med school, traveling the world, and it's nice to see them doing really well.
Okay, that was a very helpful answer, and I think the thing I took away the most is, as PCPs, we struggle to get our patients and families the mental health resources that they need, and for us to order neuropsychological testing and get it approved is pretty much non-existent. But that does put in our minds that now that if it is a cancer survivor, if we send them to you and you can get them that neuropsychological testing, I could see how that definitely would make a difference in school. And then the medical part of it would basically be just to summarize what you're saying to make sure I'm understanding it correctly. Anybody who's gotten radiation is definitely at high risk for secondary malignancy, and we should really keep that pretty high in our differential and further evaluate if that would fit with the clinical picture.
Yeah. So thanks, everyone, for giving us the opportunity to join you today. And be sure to come back on August 16th when we'll be talking about solid tumors, brain tumors, and resources in the community for these patients.
Thank you all. No more questions. Okay. Bye-bye.